to kind of do a brief walking tour through organ involvement in ECD. I'm going to do some, and then he's going to take over. And I'll sort of give the highlights of how ECD affects these organs, and then maybe with some little kind of pearls that I've found from my own experience. So my disclosures. So one of the hallmark involvements of ECD is of the bone. And it's almost invariably true that ECD involves the bone to some extent if you look hard enough. And this can be seen with PET scan or bone scan, which isn't done as much anymore, CT or MRI. And the classic location is in the legs, sort of above and below the knee. And also, it can affect sort of the bones anywhere in the body, but often tends to be further out, like far in the arms, far in the legs, as opposed to Langerhans, which is usually more sort of in the midline of the body. Bone pain is very common in ECD. There can be a lot of pain in the legs, although sort of one thing that I want to communicate is that in my experience, there's quite a gap between where pain can be and where the ECD is on the scans, and how much there is on scans, and then how much pain there is. And these seem to really kind of operate in a way that's very independent. And so sort of my kind of take homes about bone is, the pain is rarely isolated to where you see it on the scan. And there can be a great deal of joint pain as well as bone pain that really does not match up with what you see on scans. And then in my experience treating ECD patients, the intensity of bone lesions tends to fluctuate over time. I've occasionally seen that people can maybe be over-treated in order to sort of suppress what you see on a PET scan. And I always just wonder if that's always doing people a favor, because they seem to fluctuate a bit even when treatment is otherwise working. And as I said, the symptoms may not be tied to what you see. So I'm generally willing to tolerate a bit of activity in the bones and not amp up treatment for the sake of suppressing just what you see on a scan, especially in the bones. And I can see that the bones may be a little bit active even when everything else is suppressed, and that is not a calamity. And I think that is okay. And I try to sort of broadcast that message a bit. So, and then in terms of ECD affecting behind the eyes, so sort of the classic manifestation in some patients is a tumor behind one eye or both eyes, which can cause bulging, double vision, pain, or fullness. If you look hard enough, I work with an ophthalmology colleague who examines every patient. If you look behind the eye, you can often see the footprint of ECD in the retina or the choroid. That's probably more common than is appreciated. And then one of the other important things about the eyes in ECD is that because many of the ECD treatments, especially the targeted treatments, the MEK inhibitors, can affect the eye or the vision. I often suggest that patients get a really good sort of non-ECD evaluation of their eyes to make sure that any other issue that could complicate the MEK inhibitor is addressed sort of on its own terms. So, as you know, I'm a neurologist. So ECD can affect many different areas of the brain. The most common would be the back of the brain, the cerebellum or the brainstem, causing issues with speech or balance. If there's involvement of the pituitary or the hypothalamus, people can have what's called DI or AVP deficiency, where there's that hormone which tells your kidneys to hold on to water that's deficient, and there's excessive drinking and thirst. There can be other hormone deficiencies that come from that part of the brain, such as the reproductive hormones leading to fertility issues. And then patients with ECD can experience varying types of problems with thinking and memory. One thing that I always say is that there's a lot more than meets the eye in terms of ECD and the brain. We've certainly seen, sort of, I would say informally, and in some of the research that we've done, that patients with ECD, even who have completely normal MRIs, can have problems with thinking and memory, can also have changes in their mood, whether it is kind of mood instability or sort of anxiety, irritability on the one hand, but also sometimes kind of indifference on the other. And those are at odds, but they can sort of coexist, albeit kind of, even though that sounds kind of improbable, they can kind of coexist in the same person. And then in my registry study, where patients report their own symptoms, neurologic and psychiatric symptoms are the most common by far. And so, apart from sort of to take a step back from organs, I just wanted to talk about sort of symptoms generally, and that my experience has been from our work is that the symptomatology that you all have is very, very varied. A lot of them sort of, they kind of invoke the idea of inflammation that has been mentioned previously. People can have like sort of waves of heat and pain, and that's one of those sort of if you know type phenomena. And then sort of a lot of sadness and discouragement, like I mentioned, indifference at the same time. And then these things kind of improve variably with targeted therapies. Some patients experience a lot of tremendous relief, and other people, they make some of a dent and not that much. And then pain and fatigue, I know that's the topic after me, is pretty universal. And then I just want to make one sort of additional, what I think is an optimistic observation. So this was the first report that we did of patient-reported symptoms from my registry, and what it shows is that this is the categorization of symptoms, and the abundance of them is either neurologic or psychiatric, and then what we call constitutional, things like fatigue and pain. And so this is, we've looked recently at self-reported symptoms in my registry, and this is appearing very small, I realize, but so the FACT-G is an overall quality of life measure, and if you see that bold there, that's 74.3. So in 158 patients, the average sort of overall quality of life score is this number 74.3, but this survey actually has what are called norms. It's been given to thousands of people, so you can interpret that number, and that number, is unfortunately pretty low. I don't think that's a surprise to many of you that your quality of life is not huge compared to other people, and there's also high frequency of pain and fatigue and other symptom burden. But when we looked in my registry at people over time, so to scientists, if you look on the right, that's a p-value. So if that number is very, very small, that indicates a significant association. And so what we see in our patients over time is that if someone's pain goes down, or if their fatigue goes down, then their quality of life goes up over time. And that is, that's regardless of the intervention that has been implemented. But to me, that gives a lot of optimism that if you can address some of these underlying symptoms, be it fatigue or pain, or needs for greater support and information, you can actually improve people's quality of life. So I think it's a call to work on those things. And that is it for me, and I'll let Dr. Pegoraro take over.
Thank you so much, Dr. Diamond. And after Dr. Pegoraro speaks, if we could do questions for both of you, that would be great. So Dr. Francesco Pegoraro is with the Histiocytosis Clinic at Myers Children's Hospital in Florence, Italy. And like Dr. Diamond, if you want to read more about him, he's on page 17 of your program. And he's going to also talk about organ involvement in ECD. So thank you so much for being here.
Good morning, everybody. It's a privilege for me to be here speaking about this subject. I have no disclosures. I'll start with retroperitoneal involvement, which in almost all cases means perirenal involvement. It's very frequent in ECD, and we see this image that is called hairy kidneys, because you can see that in yellow we have the kidney, and what is in red in the figure is all the histiocytic infiltration that surrounds the kidney. This can be small and go unnoticed for a long time, but in some cases can have really dramatic presentation that possibly involve the whole abdomen, or can cause infiltration of the distal part of the urinary system, which means the urine output is compromised, and this can cause problem to the kidneys, both causing kidney atrophy, which means shrinking of the kidney, and or very huge dilatation of the kidneys. And in both cases, this is detrimental for the kidney function. More rarely, we can find infiltration of the adrenal glands or of the vessel of the kidney, which is why some patient can suffer for really difficult to treat hypertension. ECD doesn't directly involve the kidney. The kidney, we see this is a bioptic piece from ECD involvement of the kidney. It's not touched. It's just surrounding the kidney. We see all these loci of ischiocytic infiltration that cause fibrosis and result in what we see microscopically. I just go really short on treatment because here we have, of course, medical treatment, which is essential in the most severe cases, but we can also have ureteral procedures, which means in those cases where the urine output is compromised, we may need in the acute some stent positioning or also nephrostomy, which means that you bypass what blocks the urine output and you relieve the kidney in its function. A third option, which is I'm not sure, we are not sure about it, is transplant, which means if the kidney is really badly compromised, can we graft the kidney and to avoid dialysis? We don't have an answer, a clear answer yet. We have some work going on with our colleagues in Florence, and we have a poster at the scientific meeting tomorrow. The main message I can give on this is treatment transplant is a feasible option, but you have to really control the disease before to avoid disease recurrence in the kidney. I'll move to cardiovascular involvement. The heart is involved in half of cases. There are two main types of involvement of the heart. You have to do a cardiac MRI to see them in most cases. The most important is right atrium involvement, which can also involve the right coronary artery, which is very dangerous because it involves the blood, the distribution of the blood to the heart, the muscle of the heart, but also the pericardium, which is the sheets that surround the heart. And when this is enlarged and there is some liquid that accumulates, this can compress the heart and limit its function. We have to see the cardiac involvement is strongly associated with the BRAF mutation, which means it's very rare to have cardiac involvement and not have a BRAF mutation. We can see here what we see in the microscopic. It is we have a coronary artery, what I was telling you about before, and which is surrounded by this tissue, which is ischiocytic infiltration. And another feature very important is large vessel involvement. This is commonly called the coated aorta because we have this tissue here that really surrounds the vessels like a coat does on us. And this is most frequently found in the aorta, but can be found in every vessel in the body potentially. I just say a brief something about treatment. This is just one of the first report of interferon working on cardiac lesion in ECD. But what is new about this is we can't say that cardiac involvement is associated to bad prognosis, but what we do know is, what we do know if we treat cardiac involvement well, this is associated with good prognosis. So if you have cardiac involvement, you have to treat this aggressively to improve the outcome. Pulmonary involvement is found in is around 30% of cases. This should be investigated with high resolution CT. This is how normal lung appears, and this is what we find in ECD. We can find mostly two different patterns. It's involvement of the septa, which is the architectural structure of the lung, and and we can also have this aspect that's called the ground glass appearance of the lung. This can be asymptomatic in some cases, but can also result in very important symptoms such as shortness of breath, cough, and difficult in making efforts. I'll conclude with skin involvement. It's about 30% of patients suffer from this. This is the most typical lesion. You may know it. It's called xanthelasma-like because xanthelasma is what we find when the cholesterol is high. This is not the same situation, but it's something that it's reminiscent of that. But we can also have lesions that are completely different, erythematous, which means really reddish lesions or nodules on the skin. And the last important message is sometimes ECD can be associated to other ischiocytic disorders such as LCH. This is very common for the skin. We frequently have skin involvement that's not ECD, that's LCH, and it's important to detect this because the mixed forms are a bit different and should be evaluated and treated differently. Thank you very much.
You say the DI, diabetes insipidus, but it doesn't say if it's central or nephrogenic. Do you know if it's both?
It's central.
Which is interesting because I have nephrogenic.
Oh, that is interesting. That would be unusual.
I had a post-operative episode, an acute episode of short-term memory loss, where I couldn't find my way home. I didn't know my address. I walked in circles all day. I lost 28 pounds in 2 weeks.
I would not want to comment on that. I'd have to hear more. I'm not sure what I can say about that. Yeah.
Okay, thank you. Oh, one more thing. With the neurologic, I've had ataxia from the beginning, and it's really not gotten better. So is that what you're talking about? How it affects the cerebellum? I don't know. What do you say about that?
So I would say that there's many patients who the imbalance that they have, some improves to a degree with treatment, some improves quite well, and some just sort of stabilizes. And whether that's a function of sort of damage done, so to speak, or the drugs not fully addressing the disease in the brain, or both, is something that we don't quite know yet. But the balance problems not resolving is fairly common, I would say.
One question I had is, so, you can have a clear brain scan, but I still have all the kind of underlying issues. Have you seen, you talked about last year, have you seen any with the higher dose inhibitors, any improvements, the cognitive issues, the mood issues, those getting better in patients when they take higher doses of the inhibitors?
The cognitive and mood things?
Yeah, so balance, mood, cognitive issues.
I would say as a proof of, I think others have observed that, to an extent, yes. If you sort of blast people with very high doses, you will see some kind of improvement. I think it's a proof of principle, but not usually enough to really address it.
If there's one last question for either Dr. Diamond or Dr. Pegoraro.
Thank you. This is a question for Dr. Pegoraro. Early on in my history, there was an article written about kidney involvement, in which one proposed treatment was a procedure called ureterolysis, where basically there would be a graft of the retroperitoneum, I think, shielding the kidneys. And I was wondering is this no longer a proposed treatment?
What I can answer to this is we did 2 years ago a study with the French group of Professor Roche. We investigated extensively kidney involvement, and what we saw is that urethral procedures, any of them, nephrostomy, stenting, and even rarer things, can be useful and are certainly necessary in the acute situation, but in the long term, they're not really associated with improved function. What's at least in our results says that it's really how you treat the disease and how you treat other comorbidities that really improve the prognosis. So I'd say urethral procedures are important, but on the long term, you might want to go over that and treat the disease in more straightforwardly.